Romosozumab, the bone density paradox. Your bones get stronger, your scans look great, your doctor is happy, but you still can't climb stairs without pain, and you're terrified of falling anyway. That's not a medical failure. That's apparently just how this drug works. So what does it actually mean when a treatment fixes one problem but leaves you broken in ways the numbers can't measure? You've probably heard that osteoporosis is a silent killer. Bones get brittle. One fall and everything changes. Medicine found a solution called romosozumab, a drug that dramatically rebuilds bone density in postmenopausal women. It works fast. The results on imaging are spectacular. But a team of researchers in Istanbul just proved that spectacular bone scans don't necessarily mean you get your life back. They wanted to know if stronger bones on paper actually translate into less pain, less fear, better sleep, and better mental health. The answer? Not necessarily. The problem osteoporosis creates is straightforward enough. After menopause, women lose bone density fast, sometimes 1% per year. Fractures become a constant risk. A fall from standing height can break a hip. That broken hip often means immobility, depression, and sometimes death within the year. So for decades, we've treated osteoporosis like a bone problem. Fix the density, fix the patient. But what if bone density was only half the equation? Before this study, the assumption was clean. Increase bone mineral density, improve outcomes. Romosozumab does increase density faster than older drugs. The data looked promising. But nobody had systematically asked whether these densitometric gains actually matched up with what patients experienced. Their pain, their anxiety, their quality of life, their actual ability to move without fear. Özkan Bucak and his team at the University of Health Sciences in Istanbul decided to find out. They published their work in July 2026 in BMC Musculoskeletal Disorders. These are physical therapy researchers and biostatisticians who are used to looking at the whole patient, not just the scan. And what they found challenged one of the core assumptions in modern bone medicine. Here's what they did. They followed 46 postmenopausal women with osteoporosis who started romosozumab treatment. Everyone stayed in the study for 12 months. At 0, 6, and 12 months, researchers measured 3 completely different things. First, the obvious one, bone density. They used dual-energy X-ray absorptiometry, the gold standard scan, to measure density at the lumbar spine, the femoral neck, and the total femur. Think of it like taking a progress photo of each part of your skeleton. Second, they measured the patient experience. That meant pain levels using a visual analog scale, essentially asking people to rate their discomfort on a 0 to 10 spectrum. They also measured kinesiophobia, which is a fancy word for fear of movement. A lot of osteoporosis patients don't move because they're terrified of breaking something, even if they're actually stronger now. Third, they looked at mental health. They measured anxiety and depression using the Hospital Anxiety and Depression Scale, and overall quality of life using a specialized osteoporosis questionnaire. They were asking, does your daily life feel better? What they found was genuinely striking. The bone density numbers went up. A lot. That part worked exactly as expected. But when they looked at pain, quality of life, kinesiophobia, and psychological status, the picture got messy. Some women improved across the board. Their bones got stronger, and their pain went down, and their mood improved, and they moved more confidently. But other women improved densitometrically. The scans looked great, while their pain stayed exactly the same or barely budged. Some even reported feeling more anxious after their bones got stronger, possibly because they were now moving more and realizing other parts of their body hurt, or because the psychological imprint of a fracture risk doesn't vanish just because the numbers change. There was also region specificity, which is a nerdy way of saying that improvements didn't happen uniformly everywhere. A woman might get dramatic bone density gains in her spine, but minimal pain relief, or vice versa. The trajectories didn't sync up. The densitometric response, the clinical response, and the psychosocial response were operating on partially independent timelines in partially independent places. What this means in real terms is this. A woman could finish her year of romosozumab treatment with bones 15, 20, even 30% stronger on paper, be objectively at lower fracture risk, and still feel functionally limited, still be afraid to move, still be depressed about her health. The medication works. The medication also doesn't work. Both things are true at the same time. Now, important caveats. This was a single-center study with 46 people, which is a modest sample size. You can't extrapolate these findings to every postmenopausal woman on romosozumab everywhere. The study didn't compare romosozumab head-to-head against older treatments like bisphosphonates, so we don't know if this pattern is unique to romosozumab or whether other drugs have the same disconnect between imaging improvements and patient experience. And the researchers weren't saying romosozumab doesn't work. They were saying it works incompletely, at least in the dimensions that matter most to patients. But here's what makes this research genuinely important. It revealed a flaw in how we've been thinking about osteoporosis treatment. We've been optimizing for one metric, bone mineral density, while treating the other metrics, pain, mobility, mental health, quality of life, as secondary outcomes that would naturally follow. This study suggests they don't naturally follow. They're separate problems that might require separate interventions. A woman might need stronger bones and also need physical therapy, pain management, and mental health support. The drug fixes one part of the problem. It doesn't fix it all. This challenges the idea that disease and health are opposites measured on a single axis. You can improve one marker and still be unwell. You can be objectively stronger and still feel weak. This is actually consistent with something clinicians have always known, but that the research world keeps forgetting. Patients are complicated. Their brains and bodies and experiences don't follow the same trajectory. A person is not just their scan. The bigger question this raises is whether we're testing treatments the right way. We run randomized controlled trials measuring bone density because it's quantifiable and it predicts fracture risk. But maybe that's measuring the wrong thing, or at least the incomplete thing. Maybe we should be running trials that equally weight pain, mobility, mood, and quality of life alongside density. Maybe we should be asking patients what they actually need before we decide what success looks like. The most unsettling takeaway is this. Modern medicine found a tool that dramatically strengthens bones in ways that reduce fracture risk, and that's genuinely valuable. But we spent so long celebrating that tool that we forgot to ask whether it actually makes people's lives better. Sometimes it does, sometimes it doesn't, and we didn't know that until someone actually looked. Turns out scientists have been busy, and they're not done yet.